Everyone, this is Terry Ishmael from Shriners Hospital Children of Philadelphia, and welcome to another episode of Scoliosis Dialogues from the Scoliosis Research Society. Tonight on the show, I have my co-host, Dr. Jaysson Brooks from Scottish Rite for Children in Dallas, and we will be discussing the paper from Dr. Subaraman Ramchandran from Nicholas Children in Miami. Welcome.
Thank you, Dr. Ishmael and Dr. Brooks. It's an honor for me to be here in the SRS Dialogues. My name is Dr. Subaraman Ramchandran, and I'm a pediatric orthopedic spine surgeon currently practicing at Nicholas Children's Hospital, formerly the Miami Children's Hospital in Miami. I did my orthopedic residency back in India, after which I did a few fellowships. I did an adult AO spine fellowship at NYU Langone Medical Center, and a pediatric spine fellowship here at Nicholas Children's before I started my practice here. I'm very fortunate to have great mentors and great partners, especially Dr. Tom Errico and Dr. Stephen George, with whom I work. That is my background.
Fantastic. We're happy to have you here. So why don't you tell us a little bit about your paper? Tell us the title and then a little bit of background, why you chose it, and then, just a general spiel.
Sure. So I believe we are one of the few centers where we have, we perform MRIs on all pre-operative AIS patients, irrespective of whether or not they meet the American Radiological Association criteria. Whether it's atypical or not, we routinely perform MRIs. So we definitely have a robust database of patients, AIS patients with MRI. And as a fellow, I was kind of interested because we have had cases where we did not perform MRI, and we have had neuromonitoring issues intra-op, and on retrospect, when we went back and did an MRI, we found out that the patient had an intraspinal anomaly, a neural axis anomaly. So we kind of do this on a routine basis. The purpose of this study was inspired by previous literature from by Cialetki et al. In 2020 and Matthew et al. In 2021, when they published their results of intraoperative neuromonitoring changes in spine deformity patients based on the type of the spinal cord at the apex, where they defined a classification system and a graded classification system, and they kind of correlated the intraoperative neuromonitoring alerts based on what type of spinal cord the apex is. So that kind of inspired us to do this study. The one different thing about a study is that we have done this purely on an AIS population. The first study that was published in 2020 was done in both mixed of adult and pediatric population. And the study done by Matthew was done in all pediatric spinal deformity patients. But ours is purely AIS patients who do not have intraspinal anomalies that we found. The other thing we wanted to kind of highlight in our paper was to see the relationship between the MRI spinal cord and the radiographic parameters to come up with a plan of how we can effectively use MRI to screen patients to predict which patients will have a higher number of higher chance of developing an intraoperative neuromonitoring alert.
Very interesting. So, I know that at my center in Philadelphia, we get MRIs routinely on all spines. What about you, Jaysson?
So,
Hello?
Can you hear me?
Yeah.
Perfect. So we are actually quite different. So we routinely do not get MRIs unless they do have some concerning signs when it comes to either their physical exam, whether they have, hyperkyphosis instead of hypokyphosis, or something else that just seems off. And so, when I was listening to you talk about what your routine is, I guess the first question that popped into my mind is, that seems like an immense use of overall healthcare resources. And so I guess what is driving this? Is it a medical legal concern, or is it a concern that you all might be finding more type 3 cords and more neuromonitoring changes? Like, what is actually driving that, since it would seem to be an immense cost to do that for every patient?
I think it primarily is medical legal, as well as the fact that we have had issues in the past where we have not done MRIs, and we have had neuromonitoring alerts. And when we went back, we saw that the patient had, although the patient was asymptomatic, not an atypical patient, not an atypical scoliosis, the patient had intraoperative neuromonitoring alert, which we thought it could be related to having an intraspinal neuroanatomic anomaly. So that kind of triggered us to do MRIs on all kind of preoperative AIS patients.
Yeah, I think it's a fine balance, right, between resource utilization and kind of risk mitigation, right? I know that in Philadelphia, I mean, it's probably one of the more litigious medical societies around, and I think part of it is like you were saying, Subbu, making sure that we're not missing anything with the evaluation, and then too also medical legal as well. So it's a tough decision.
Right. I think in this paper we kind of highlighted that I believe that MRI should not be the first screening modality to predict an intraoperative alert, and that's why we wanted to use some radiographic parameters that can guide us to better understand this. I know there's a lot of debate, in a lot of places don't do routine MRIs, even for a typical AIS patient. But I guess we kind of came up with some radiographic parameters that we found had an increased chance of an intraoperative alert. And when that radiographic parameters threshold was met, and in combination with the type 3 spinal cord, then the chance of having an alert was significantly higher. So I guess I completely
if you can
agree.
go through those, radiographic parameters, that would be awesome.
Sure,
for our
yes.
listeners.
Absolutely. So the first radiographic parameter we found was Cobb angle, the main thoracic Cobb angle more than 65 degrees. And what we found that when we have a main thoracic Cobb angle of more than 65 degrees and a type 3 spinal cord at the apex simultaneously, then we had almost a 50% chance of having intraoperative neuromonitoring alert in a AIS in the AIS population. The second parameter was the apical vertebral translation. When the AVT was more than 5 centimeters with a type 3 spinal cord at the apex, then the chance of having an IONM alert was about 35.2%. And the third parameter was the coronal deformity angular ratio. And when the CDAR was more than 10 with a type 3 spinal cord at the apex, we found that the rate of IONM alerts was about 43.7%. So those
That's
were
really
the
interesting.
yeah.
So then I guess my follow-up question is, now that you all have that data, are you going to change your hospital practice to only get MRIs on those patients? Or are you still going to get it on everybody?
No, possibly we will. We are discussing that with our team.
What do you think, Terry? Do you think that they're going to do things differently at Shriners? Is this paper going to change practice in Philly?
For the most point, and I mean, a lot of the curves that we end up seeing are fairly significant, like greater than 65 70 degrees. So I think there's a good case to get those in all of those patients. Like I trained in Dallas, so I definitely came out of there. We I don't need an MRI. We'll just examine them. We'll check the abdominal reflexes, and we get a good history. We should know most things. And then I came to Philly to finish my training. And then it was kind of like, oh yeah, we're just going to get it anyway. And it gives good information. If there is an intraspinal anomaly, then if you really want, if you have a good quality MRI, you can measure some pedicles and have a better idea of the anatomy. So I mean, again, I get them. It's probably not going to change anything that I do.
So that's really interesting. So follow-up question I had, and again, sorry, I just think this is really interesting, is when it comes to the alerts that you talked about. So there are alerts, and then there are changes, right? Changes that actually you have to actually do something about. And so I guess what you all, I don't know whether, for reading through the paper, I couldn't quite tell whether the MRI findings of a type 3 cord or the alerts that subsequently happened actually made you do something differently in your surgery, right? So if I knew I was going into the case with a type 3 cord, we all know that Lenke's paper talks about potentially doing a PSO to take down that pedicle so that cord is not being draped over that pedicle. I would presume most of us are not having to do that routinely for most of the patients with the type 3 cord. So I guess what with the information that you've obtained from this MRI, going into the case, knowing that you're dealing with the type 3 cord, is that changing how you approach these cases?
Knowing that we have a type 3 cord, we are more alert. It doesn't change our routine way that we do the cases, but we kind of have a thorough discussion with the anesthesia and the neuromonitoring team before that. We have a high risk patient here because of the cord that we have seen, the type of the cord that we have seen the apex. So we try to keep the map higher most of the times, even during exposure. We and if we get any signal changes, then we go back to doing a little compression on the convex side, doing an asymmetric Pontes on the convex side, doing compression on the convex side. But to be honest, in our data set that we have seen, we had 12 neuromonitoring alerts, and we did that procedure only 2 times out of 12. Because most of the alerts, about 50% of the alerts were secondary, we thought secondary to hypotension. And this study is not, this study is a retrospective study. I don't think it's appropriately designed to answer that question, whether the neuromonitoring alert was a cause of this type of spinal cord in this particular patient. It was only designed to study an association between intraoperative alerts and the type of cord at the apex.
What about you, Jaysson? Do you do anything different? Like, let's say you've got like a 90-degree curve, a high DAR. Do you routinely get the MRIs on those patients?
So usually not. I know the things that make me get an MRI are usually if I see kyphosis there, or if it looks like there's rapid progression. And so we are rarely getting it. But again, many times if we see a very big curve that looks like it's rigid, we are hanging these kids up in halo traction, which potentially may give us a little bit of a pass when it comes to these type 3 cords, because if we're slowly stretching them out and then fusing them a couple weeks later, that may potentially decrease those risks. So that might be a confounder a little bit in how some people are approaching these, rather than doing just the acute corrections. And so it might be interesting, like to even look at a sub cohort, Dr. Ramchandran, of your patients who had type 3 cords and underwent preoperative halo traction, if you saw potentially the risk of alerts dropping down even more with the same criteria that you have, just to see, is that potentially like a way around that?
Absolutely, I agree. I completely agree with that. In fact, the patient that I was talking about, which I clearly remember, was the one in which we had done a halo gravity traction prior. It was a very, very severe big curve, and despite that, we had an alert, so we had to go back and do the asymmetric Pontes and compress the convex side. Yeah.
Yeah, I mean, I think that, like, there's some curves which, will definitely, make you pause and kind of think about it a little bit more. Like anytime, I'm doing anything bigger than 90 degrees, and it's usually myself and a fellow, like I'll talk to one of my partners and say, hey, who's around? I operate on the same day as Amr, and he's usually in the other room, or one of the other partners are in clinic. I'd be like, hey, I'm doing this. Just if you're around, I may give you a call just to come down. And it's happened like not infrequently. Like, I mean, there will be something that'll happen even on a smaller curve, and I'll just ask one of them to come take a look. But definitely for bigger curves, I will go out of my way to discuss with somebody and be like, hey, just in case, this is what I'm doing. You may get a call.
Perfect. So this was a really excellent paper, Dr. Ramchandran. How many years into practice are you now? Like, how many years have you been at Miami now?
I'm at the Nicholas Children's Hospital since 4.5 years.
Okay, so we would definitely consider you an early kind of career surgeon, and one of the earlier surgeons in the SRS, with already an awesome publication in our journal. I guess, what advice would you have for some of our listeners who are kind of early career surgeons on kind of starting out their spine deformity practice? Any kind of words of wisdom you want to give them as we start to close up this podcast episode?
I truly believe that I'm very fortunate. I truly believe that evidence-based practice is kind of very important, especially when we're dealing with these very complex group of population. And we do very thorough pre-operative conferences. We do very rigorous planning, and I always operate with one of my senior partners. So I think for me, it's very important to have a senior partner, just because I learn constantly, and as well, I think it's much safer for the patient. And regarding research wise, I truly believe that we should constantly try to like think about and brainstorm and try to come up with ideas, and pursue and start the data collection to do the homework. And I think it's a good way to learn more. It's a good way to be engaged, and sometimes you get lucky, you get called in SRS podcast. So I guess
And it's well deserved.
thank
Great
you, sir.
paper.
Thanks, sir.
Well, guys, I mean, I think that's it. Thank you very much for joining us, Dr. Ramchandran, and on behalf of myself and my co-host, Dr. Brooks, we'd like to say goodnight, and thank you, everyone, for joining us.
Thank you, Dr. Ishmael. Thank you, Dr. Brooks. Thank you, SRS. Bye.
Awesome. Take care.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.